So we are going to get started. Welcome everyone here to Neurology Grand Rounds, and welcome to our folks at Harborview Children's and elsewhere. So it is a delight to present Dr. Courtney Francis, who is an assistant professor in ophthalmology, but also a neuro-ophthalmologist. So that's very exciting, and she'll give us some interesting discussion today. So Dr. Francis did her undergraduate at Brown and an honors thesis on optical method of staining retinal ganglion cells. So clearly there was an interest already burgeoning. She got a medical degree at Rochester and then went on to an ophthalmology fellowship at UAB in Birmingham. And then, I had to say this, not losing sight of her goals, she went and did a neuro-ophthalmology fellowship at USC, and we had the pleasure and the good fortune of having Courtney come to the University of Washington, where her research or her clinical interests and focus has been on the diseases that are the union between neurology and ophthalmology, so cranial nerve palsies and optic neuropathies and ophthalmological and manifestations of neurological diseases like multiple sclerosis and myasthenia gravis, and she's published on these subjects as well. So it is, no further ado, I will present Dr. Courtney Francis. Thank you for coming.
Thanks. Just put this around my neck. Okay. Well, thank you so much for having me. It's always a pleasure to talk to neurologists because sometimes there are things that you guys understand more than the ophthalmologists do that I see every day. So it's a pleasure to be here. And I'm going to be talking today about idiopathic intracranial hypertension, which is a disease that is definitely an overlap between ophthalmology and neurology. So just, starting with a typical patient, a 34-year-old woman comes in for evaluation of disc edema. She's obese, reports headache for the past 6 months, and some episodes of transient vision loss. And when we look in the eyes, we see some, I don't know if you guys are able to make that out too well, but see some swelling of both of her optic nerves. And then she has a visual field test, which shows some classic findings of enlarged blind spots and inferior nasal steps in both eyes. So this is pretty typical for a patient that we would see and diagnose with idiopathic intracranial hypertension. So over the next hour or so, my goal is to discuss the presentation and findings of papilledema, differentiate papilledema from pseudopapilledema, discuss the diagnostic criteria for IIH, the treatment options for the disease, and then also review the results of the recent IIH-TT, or idiopathic intracranial hypertension treatment trial. So what is papilledema? So papilledema is bilateral disc edema secondary to increased intracranial pressure. The term is often misused for any type of disc edema, but we really, in neuro-ophthalmology, reserve it for disc edema related to increased ICP. And it may be asymmetric, but it is typically bilateral. It can be associated with other signs and symptoms of increased intracranial pressure, and we typically evaluate it by doing neuroimaging, usually an MRI and a lumbar puncture, and often requires a somewhat urgent workup. So why do we see swelling of the nerve? Well, the nerve fibers that make up the optic nerve get compressed by elevated CSF pressure within the subarachnoid space of the intraorbital optic nerve, leading to axoplasmic stasis and disc swelling. And then from that, you can have secondary venous obstruction and dilation, nerve fiber layer hypoxia, and vascular telangiectasia. The symptoms of papilledema vary. Oftentimes it's visually asymptomatic, which can actually, as an ophthalmologist, help us differentiate from other causes of disc edema. They may have headache, but as you all know, headaches are pretty common. Transient obscurations of vision, which are a gray out or black out of vision, unilateral or bilateral, lasting seconds and then clearing completely, and often associated with changes in posture. They may have double vision, or they can also have pulsatile tinnitus. On exam, when we're seeing a patient with papilledema, the visual acuity is usually intact, actually decreased.
May I ask why you would have double vision?
From a sixth nerve palsy, from increased
I see.
intracranial pressure.
Not from papilledema
No.
per se?
No. Although patients often have monocular diplopia, which is a whole other issue. But so decreased vision in papilledema is a late finding. That's when it's really bad. So usually their vision on the eye chart is typically pretty good. They may have visual field defects, however. Typically, the most common would be in a large blind spot, which is usually not too worrisome. But then they can get an inferior nasal step, and then some, further peripheral constriction, and then late would be just generalized depression and decreased acuity. If they have asymmetric swelling, asymmetric papilledema, they may have an afferent pupillary defect, and we may see a sixth nerve palsy related to the increased intracranial pressure as well. So when we're evaluating papilledema by looking at the optic nerve, we have a certain way of grading it and then determining, how long it's been there. So in early papilledema, there may be some mild changes prior to the development of disc edema, where we just see some opacification of the nerve fiber layer, some graying of the nerve fiber layer as it comes into the optic nerve. The disc may appear hyperemic. We may see some nerve fiber layer hemorrhages and the absence of spontaneous venous pulsations. SVP are typically seen about 80% of the time in normal intracranial pressure. They disappear around 20 centimeters of water. So if we see them, it's helpful. If we don't see them, it's not as helpful because 20% of the time they're just not present. In fully developed papilledema, we see anteriorization of the disc, so it appears to be coming forward into the vitreous. There's swelling of the nerve fiber layer obscuring the disc margin. We can see flame hemorrhages and infarcts of white areas on the surface of the optic nerve, Patton's lines, which are areas where there's so much fluid it's pushing the retina next to it. You can start getting exudates in the macula and hemorrhages there as well. And then with very severe rapid increase in intracranial pressure, sometimes we'll even see hemorrhage that extends into the vitreous cavity. With chronic papilledema, oftentimes those hemorrhages and exudates resolve, and we see this kind of what we call champagne cork appearance of the optic nerve, where you really don't see any of the central cup. The nerve can look less hyperemic and start appearing kind of more milky gray in appearance. You can get these chronic heart exudates on the surface of the nerve, and then we start seeing loss of the nerve fiber layer. And then even further, we start getting secondary optic atrophy, where the disc starts appearing atrophic and pale, and we can see sheathing of the retinal vessels coming off of the nerve, and then potentially optociliary shunt vessels, which are abnormal vessels between the dilation of the arterioles there, and then some peripapillary retinal pigment epithelial changes. So there's quite a progression of untreated papilledema. So oftentimes I'll get referrals for patients, is this papilledema or not? Because nobody wants to do a lumbar puncture unless they need to. So the differential diagnosis, when we're evaluating, thinking about a patient with possible papilledema, the most common thing in the differential would be pseudopapilledema. So the nerve looks like it's swollen, but it's actually just kind of a normal variant, potentially. What we call a congenital anomalous disc. It's just funny looking. Or they have optic nerve head drusen beneath the surface, making the disc look very full but not swollen. Or some sort of papillitis, which is an anterior optic neuropathy, and non-arteritic anterior ischemic optic neuropathy, which would have a very different presentation from papilledema. Diabetic papillopathy, which if it's can be somewhat more challenging to differentiate because it can have kind of an indolent course where it's incidental on exam or with minimal visual changes, and if it's bilateral, can actually mimic papilledema. But it's usually due to underlying diabetes and just has a self-limiting course and resolves on its own. And hypertensive optic neuropathy, of course, is always in the differential and neuroretinitis. So when we're thinking about papilledema versus pseudopapilledema, there are certain things that we can look for on the exam of the optic nerve to differentiate. So in papilledema, we start seeing obscuration of the vessels on the disc, whereas in pseudopapilledema, the vessels should appear very clear. With papilledema, with the swelling, we can see some elevation and obscuration of the peripapillary nerve fiber layer, so some graying or feathering of that, where that shouldn't occur in pseudopapilledema. And there are a number of different things that we would look for to evaluate between the two. But sometimes it's relatively simple to differentiate, and other times it's can be a bit more complicated. So when we're evaluating papilledema and grading it, we have a grading scale from 0 to 5 called the Frisen scale. And this is really important because when we're following patients with papilledema and we want to know if they're getting better or not, we have to, rather than just saying, oh, it's 1+, 2+, it looks a little bit better than last time. We actually have specific criteria to look for, and so we can follow these patients over time to know if their disc edema is getting better or worse. So grade 0 would be no disc edema. Grade 1 is a C-shaped halo with so a temporal gap. So you can see that there's some feathering here of the nerve fiber layer. It's a little bit hard to nearly 360 degrees, but temporally here there's no swelling. So it's a C-shaped rather than 360 degrees. So if it doesn't go all the way around, we call this grade 1 papilledema. As opposed to grade 2, where the swelling is 360 degrees. Are you guys able to see the images okay?
If you want to, you can turn down the lights above the screen.
So in grade 3 papilledema, there's 360 degrees of swelling, and then there's obscuration of a major vessel as it leaves the disc, so on the disc margin. I can use this. This is easier. So you can see you start losing that vessel at the disc margin there. So that would make it a grade 3. In grade 4, there's loss of a major vessel on the disc. So you can see, you can't make out this vessel here, but you can see as it's coming off the disc. And here as well, you lose those vessels. And that's due to opacification of the nerve fiber layer from swelling. And then in grade 5, it's partial or total obscuration of all vessels on the disc. So you really can't, other than this one here, there's a lot of obscuration of the disc vessels. And so by using this grading scale, it's actually a quite accurate way of tracking people over time, and this is what we use in clinical trials as well. Yep.
So if I'm saying there may be some obscuration of the disc margin, but it's only temporal, does that mean it's not papilledema?
So probably not.
Can you repeat that question?
Oh, sorry. So if there's obscuration and it's only temporal, then it's unlikely to be papilledema because it's actually classically nasal and then you get temporal last.
Can I ask a question? It was my understanding that the anatomic changes of papilledema can become a little bit fixed. So if you see a patient, for example, that's being aggressively treated for the intracranial hypertension, the picture of the disc may go unchanged for several days or a week or more.
Yes,
even though
yeah.
the pressure's gone.
So the question was in terms of the timing of the changes of the appearance of the optic nerve in the setting of treating.
And how useful it is to follow these changes is a real reflection of the
So I'm
patient's-
talking about over weeks as opposed to days in terms of how we see the changes. Yeah, we're not necessarily going to see changes immediately. So, you know, in terms of causes of papilledema, you guys are all aware of this. You know, in addition to the intracranial hypertension, of course, we're worried about a mass lesion, meningitis, hydrocephalus, venous sinus thrombosis, and rarely a Chiari malformation. So what about idiopathic intracranial hypertension? This is our preferred name as opposed to pseudotumor cerebri or benign intracranial hypertension. IIH is the easiest way to say it. This is a diagnosis of exclusion. We have to rule out other causes of increased intracranial pressure. We know it's most commonly in young women of childbearing age that are overweight. The incidence is about 22 in 100,000 of overweight women of childbearing age. And we do know it can be associated with the use of certain medications such as vitamin A, steroids or steroid withdrawal, tetracyclines, lithium, and oral contraceptives. So the signs and symptoms are that of increased intracranial pressure. So the majority of these patients have headaches, about 94%, but that's not very specific for IH. These headaches, as with other headaches of increased ICP, can be worse with Valsalva, worse in the mornings after they've been lying down. They can also have transient obscurations of vision, so those grayouts I was talking about, horizontal diplopia, and actually probably the most specific symptom that they may present with is the pulsatile tinnitus. The signs should be that of increased intracranial pressure, so papilledema and potentially a sixth nerve palsy. So just to review the modified Dandy criteria for how we diagnose IIH, the signs and symptoms on exam should be that of increased intracranial pressure and or papilledema and nothing else. They need to have a documented elevated intracranial pressure from a lumbar puncture, normal CSF composition, no other findings on the MRI to explain it, and no other systemic causes of increased ICP. So really you have to rule out everything else. And these patients really do need to have a confirmed elevated opening pressure and lumbar puncture to make the diagnosis. Otherwise, you can say it's presumed or possible, but really, unless you meet all these criteria, you can't say for sure. And so to evaluate, we typically would want an MRI of the brain with contrast, possibly an MRV, especially an atypical presentation. So if it's a thin person, a man, outside of the typical age range that we would expect. And then the lumbar puncture with opening pressure and cell count. So the MRI should be normal, but we do expect possibly to see some MRI signs of increased intracranial pressure. So those include flattening in the posterior sclera. So you can see rather than being the normal rounded posterior aspect of the globe, it's flattened because of the increased pressure. We can see distension of the perioptic subarachnoid space, so there seems to be increased fluid around the nerve there. Enhancement of the prelaminar optic nerve, so you can actually see that papilledema there. Vertical tortuosity of the orbital optic nerve, so you can see there's that kink there, and then an empty cella. So while we say the MRI should be normal, there can often be signs of increased intracranial pressure on the MRI. So how do we evaluate these patients? As an ophthalmologist, we're concerned about vision. So these patients get sensory visual testing with visual fields. So we follow them with serial exams, visual fields. We document the disc edema with photos so that not only do we describe it with the Frisen scale, but when they come back, we can compare what they look like in the clinic to what they look like on presentation with color photos. And then the perimetry or visual fields is the most sensitive for detection and characterization and monitoring of their vision loss. Visual field changes are found in the majority of patients on presentation. And we know that Snellen acuity, so what they're able to read on the eye chart, color vision testing, confrontational visual fields are all inadequate in picking out these visual field defects. So the visual field progression of untreated papilledema, the earliest finding we see is an enlarged blind spot, as I said earlier, and then an inferior nasal step, and then they can develop arcuate scotoma, so either inferior or superior arcuate defects, which would be like this. And then more peripheral constriction, so basically the arcuate defects are just connecting, and then general depression, and that's when they start losing their central vision. So this is what we're trying to prevent with treating the disease. So how do we treat it? So medical management, we know that weight loss can be very effective in the long-term management of this condition. We usually look for a 6 to 10% reduction in weight, and that's with a low-sodium diet. But I also know that surgically induced weight loss is just as effective. So if patients undergo bariatric surgery, it can be quite effective in treating this condition. And then there's acetazolamide, which has been our standard treatment for this, usually starting at 2 grams, going up to 4 grams, typically avoided in the first half of pregnancy. There hasn't been a lot of hard evidence previously about using Diamox, but everyone thought it was very effective. And so that was one of the reasons for the recent IHTT, and I'm going to get into that in just a few minutes. But that's kind of been our mainstay of treatment. In addition to Topamax, which we use for a few different reasons. It is a carbonic anhydrous inhibitor like Diamox. It can promote weight loss, and it's good for lots of different types of headaches.
Can I ask a question?
Yeah.
So it sounds like there's an association with obesity, and weight loss can really help sometimes. It does make a difference. What's the connection?
It's a good question. So the question is, what's the connection between obesity?
Why do some obese people develop?
Right, because if you think about the number of patients that are obese and then the number of patients with IH, it's actually a small number of them, and that's a question that is yet to be answered. Part of the IHTT was looking at CSF analysis to look at hormone levels and leptin and things like that, and I don't think they didn't have any results from that were significant at this time. So it is a question that's yet to be answered. Yeah, Eric.
The acetazolamide dose. So lower doses don't work at all. I tend to underdose, I guess, when I start like 250 twice a day.
We would call that a homeopathic dose.
Okay, so you want to get up.
So the starting dose, at least in the IHTT, was 1 gram a day. I'll get into the details of the study a little bit earlier. I usually start 1 to 2 grams, depending on the severity of the symptoms and the vision loss.
If you look at micromedics, it doesn't look like it goes up to 4 grams. You should never get that.
Yeah, that's when the pharmacy starts calling. But so again, and I'll go over the results of the IHTT, but 4 grams has been shown to be safe and tolerated.
I totally get it, but I echo Eric's consideration. At 250 milligrams twice a day, you inhibit about 98% of carbonic anhydrase activity. So what is the other 3.5 grams do?
Weight loss.
I've never read that it has anything to do with it.
So we're getting ahead of ourselves, but let me just get through this, and then we'll go through the results of the IHTT, and some of those questions may be answered. But yeah, I do find that neurologists tend to start at lower doses of Diamox than we do in ophthalmology. I think probably because we're concerned about impending vision loss, and so treat a little bit more aggressively. But typically, I start at 1 to 2 grams, and then I don't tend to keep patients on 4 grams for an extended period of time. It's often a bridge to surgery at that point if they're getting up that high. But patients in the IHTT were up to 4 grams. And I will combine acetazolamide and topiramate. That always gets a call from the pharmacy as well. kind of third line treatment would be furosemide or methaczolamide. I don't tend to use those as much, but for patients that are unable to take the other medicines, it's something you can consider. Steroids are somewhat controversial in the treatment of IIH. It can make weight loss more difficult and rebound swelling on withdrawal. If someone comes in with what I term malignant IIH, so very rapid onset with rapid vision loss, I will treat them with a short course of IV steroids as I'm getting ready to take them to surgery. Basically, that's the only time that I will put someone on IV steroids. And then serial lumbar punctures, not too many people do those anymore. The effect is very, short-lasting unless you get a leak. Sometimes with pregnant women as a bridge to something else, but this is not something that is found to be effective kind of long-term for the treatment. So when do we take these patients to the operating room? Well, if they fail or are intolerant or non-compliant with medical management, then we want to consider doing something surgically. If they have worsening visual fields or worsening acuity, severe vision loss at presentation, or headaches that are unresponsive to treatment. So we have two options. You can either send that patient to me, or you can send them to the neurosurgeon. So for a shunt, that's either a LP or VP shunt, and these are typically for patients where headache is the main indication for surgical intervention. These can be quite challenging for them because of the lack of ventriculomegaly. They are at high risk for developing a complication, needing shunt revision or possibility of infection. These patients have very high rates of shunt failure. But in patients that are non-responsive to medical therapy and have severe headaches, it is a good option. But in ophthalmology, we prefer the optic nerve sheath fenestration or optic nerve sheath decompression. But these are usually reserved for patients that have vision loss as their primary complaint. We do know that patients may actually have bilateral improvement from a unilateral procedure, so we don't have to put them through the risk of a bilateral procedure necessarily. Sometimes they do end up needing both sides done. And there are complications, including double vision, vision loss, and a dilated pupil. Vision loss is thought to occur in about 1% to 2% of patients. These don't last forever, however. 75% are functional at about 6 months, but only about 16% at 6 years. But we do know that IH is often a disease that runs its course and then resolves at that time. And it may have a weak improvement in headache, but oftentimes patients still have headaches that need to have treatment. So how do we go and get to that optic nerve, you wonder? So I do what's called a medial approach, where, sorry, I don't know if you guys are grossed out by eyes, but so basically, this is the nose. This is the eye. So this is a medial conjunctiva, which is taken down, and we're able to see the medial rectus muscle. And then we actually disinsert, I think this is the other side, sorry. We disinsert the medial rectus muscle from the wall of the eye and put in what's called a basketball suture here, so we can apply some traction to rotate the eye over. And so you can see here the assistant is applying traction to this medial rectus insertion. And then we track back behind the eye until we see the optic nerve. And then we use a blade to fenestrate the nerve. And we can see, when we see a fluid gush, we know that we've got CSF. Sometimes we'll put in a window that's potentially going to stay open longer. Sometimes the access is limited and we're not able to do that though. So we'll just do multiple fenestrations to relieve the fluid pressure directly at the nerve. And then we, once we do that, we sew the muscle back on, close the conjunctiva, and that's the end of the procedure. So with the the medial approach or with the lateral approach, there's risk of double vision because we are disinserting a muscle from the wall of the eye and reattaching it. The potential for a dilated pupil is we're actually getting near the ciliary ganglion behind the eye, and so if we traumatize that, they can end up with an 80s pupil. That's less likely with the medial approach, just given the anatomy back there. Yeah.
Do you ever do a third ventricular as opposed to
Well, it's not hydrocephalus or obstructive, so I'm not sure that's.
And the amount of fluid leak is so minor that it's not collecting around the eyeball.
Sometimes we can actually see a little bit of a bleb on the surface beneath the conjunctiva. That's actually, a good sign. But yeah, it just kind of trickles out.
You don't damage
So that's, there is a 1 to 2% risk of vision loss from the procedure. So, if you think about IIH, I mean, it's high pressure, it's the nerve sheath is kind of tense, and so when we go into fenestrate, there's that, quite a gush sometimes. And so that nerve sheath is, there's a little bit of a barrier. If you were to go in too far, you'd be into the nerve fibers, but not when you just do the nerve sheath.
A week after doing this, if you do an LP, is the pressure down to normal?
Not necessarily, no. So that's
Does
why
the pressure even change?
there can be a small change in the pressure, but it's not significant.
So they may still have intracranial hypertension.
Correct. So they may still have headache that's needing treatment. So, there are some people that really advocate for optic nerve sheath fenestrations, others that feel like a shunt can potentially take care of all of it with the headache and the vision loss. Our concerns are always, the risk of complications from the shunt, risk and need for revisions over time. And so if we're able to control the headache medically and get them through this period of time where they're having severe vision loss, maybe better long-term for them. So this condition is often self-limited. However, a quarter of patients develop vision of less than 2200 in the worst eye, so fairly significant vision loss. And this, eventually, if a nerve, is swollen for too long, it becomes atrophic over time. Risk factors for poor prognosis include systemic hypertension, age, lack of headache, and non-ophthalmologic follow-up because of the need for serial visual field testing, and that's something that we're able to provide.
Age being older age?
Younger,
Younger is poor prognosis.
pediatric. So previously, the treatment of IH was based kind of on anecdotal evidence. If there was no vision loss, we would recommend weight loss. We would consider Diamox if they had severe papilledema. If they had mild mild vision loss, we would talk about weight loss, start them on Diamox, ramp up the Diamox. If they still had progression, then they would get surgery. If they had severe vision loss, we would do all of that, but maybe take them to surgery sooner. So there was definitely a need for a trial because we just really had only anecdotal evidence up until recently. And we wanted to know, the safety of Diamox, if it was actually effective, and to potentially determine the etiology. And so that's what started the IIH-TT, or Idiopathic Intracranial Hypertension Treatment Trial. So the question was the efficacy of a low-sodium weight loss diet plus Diamox versus diet alone. So this wasn't Diamox versus diet. Everyone was put on the diet, and they either got a placebo or Diamox. And the primary outcome was a change in the parametric mean deviation from baseline to 6 months on the visual field. And then they also looked at the change in papilledema grade, the intracranial pressure, other quality of visual field measures, and quality of life measures. And the entry criteria included patients ages 18 to 60 that met the modified Dandy criteria. They had to be newly diagnosed, so they couldn't have previously been treated for IIH or had an optic nerve sheath fenestration or shunt. They had to have papilledema, and this was mild vision loss, so a parametric mean deviation of -2 to -7. So this is kind of the typical visual field. So enlarged blind spot and inferior nasal step. So these weren't patients with severe IIH with vision loss. And so they were stratified into two groups, one that received the acetazolamide and one that received placebo. And then they also, everyone got the genome-wide association study with the CSF, which I don't have any results for that at this time. And then they were followed for 6 months, and then the endpoint was the MD at 6 months. And there were 165 patients that were enrolled in the study. And as expected, the majority were women. There were only 4 men enrolled. The average age was about 29. 88% were obese with a mean BMI of 39.9. And interestingly, 5% of patients identified family members with IIH. And it was felt that this group represented about 1/3 of all IIH patients with this degree of vision loss. And so you can see 317 patients were assessed for eligibility, 152 were excluded, the majority just not meeting eligibility criteria. So either their visual field was too bad, they had unreliable visual fields, the CSF opening pressure was not high enough, it had to be 25 or higher. Those were the main reasons. And so 165 were randomized, 86 received Diamox, 79 received the placebo. And then the primary analysis included all of those, including patients that withdrew or discontinued the medication. And if you see here, 7 in the Diamox arm discontinued the medication, and so this may, but they were still included in the final analysis, so that this may have had some effect of the what they thought was potentially decreased effect of the Diamox overall in the final results. And so patients were started on 1 gram a day, and then they were titrated up as needed. And so you can see over the course of the trial, patients in the Diamox group, their average dose was 2.5 grams, and in the placebo group, they were 3.5 grams. So they were titrated up further, assuming they weren't seeing an effect from the medicine. And but a fair number of the Diamox group got to 4 grams. And this was kind of a typical visual field, like I was saying. So this inferior arcuate enlarged blind spot with a MD of -4.41. That's basically how depressed it is compared to age and match controls. And so if you look at the primary outcome, which was a change in the mean deviation in the worst eye, after 6 months, you can see the effect of acetazolamide plus diet versus placebo plus diet was an effect, treatment effect of 0.71 decibels. And you can see that this effect was actually quite significant early on. And I think the thought would be these patients were losing weight and so had some improvement over time, whereas this group was put on treatment and so had more rapid improvement and had continued further improvement compared to the placebo group.
How much weight did the patients lose?
I'll get to that in just a second. So if you look at the change in papilledema grade for the worse eye, you can see that in the Diamox group, they had a much more significant improvement in the grading of the papilledema in the worse eye compared to the placebo group. And if you do a subset analysis of the patients with the worst papilledema, so Frisen grade 3 to 5 versus the 1 to 2, they actually had a more significant improvement in the mean deviation. And there were 7 treatment failures, 6 of which were in the placebo group, and only 1 in the acetazolamide group. So these were patients that had, titrated up and had a significant drop in their mean deviation on visual fields and were withdrawn from the trial. And the placebo group was placed on Diamox. And I believe the one in the acetazolamide group ended up needing an optic nerve sheath administration. So the weight loss target was 6%. The patients in the placebo group lost close to 8 pounds, whereas in the acetazolamide group, they lost significantly more. So this was a little bit of a surprise. So Diamox actually led to quite a bit of weight loss. They were both on the same weight loss program, but now we know that Diamox can help with weight loss as well. Before, I always, would tell patients that Topamax can help with the weight loss, but now we know Diamox is actually quite effective as well. I mean, that was quite a significant difference between the weight loss in the 2 groups.
If you've ever taken acetazolamide, it doesn't make you feel like sitting down to a steak dinner and turning to your down.
Well, that may be what these patients need. And then if they looked at a number of different quality of life measures, and all of them had improvement in the acetazolamide group versus the placebo group. So even though they're getting that numbness and tingling and feel horrible on the Diamox, their quality of life measures were actually much better. And then, not everyone in the study agreed to the lumbar puncture at 6 months, but those that did, there was a significant difference in the opening pressure in the Diamox group versus the placebo group. In terms of adverse events with acetazolamide, there were 9 adverse events, including 3 in the placebo. 2 patients had kidney stones, both of which were in the acetazolamide group. Transaminitis, pancreatitis, diverticulitis, and of course paresthesias and fatigue, nausea, vomiting, all of the things that we expect with Diamox. So I don't typically follow these patients with labs when I put them on Diamox, but I know there's been some concern for patients with aplastic anemia and with hypokalemia. However, it was shown that there was not a significant difference in potassium levels on Diamox versus placebo, and so it was not recommended that these patients get followed with serial labs. So in terms of the study limitations, this was limited to patients with fairly mild vision loss, and so this may have decreased the effect seen from the Diamox. If we had included patients with more significant vision loss, we may have seen a larger improvement in their visual field. And there was a 19% withdrawal rate from the study. So in terms of the secondary outcomes, there was a significant improvement in the PMD in the fellow eye. the papilledema grade, and the quality of life and visual field measures. There wasn't a significant improvement in the visual acuity, but we do know that that's typically a late finding in papilledema. So in conclusion from the IHTT, it's felt that acetazolamide led to significantly improved visual field function, papilledema grade, quality of life measures, and CSF pressure. It was well tolerated and felt to be safe up to 4 grams. And so the neuro-ophthalmology community recommends using the maximally tolerated dose of acetazolamide plus diet to treat IH patients with mild vision loss. So what's next?
Could I ask
oh,
a question?
yeah.
So the diet treated group you said lost 8 to 9 pounds. I missed. Did you say what the acetazolamide
I think it was,
18.
So double.
yeah, it was quite, I think it was about 17.
17 to 18.
So it was a significant, but they also, in the analysis, they controlled for that, and they felt like that improvement in the visual field PMD was independent of that additional weight loss.
So there was an attempt to sort of correlate the amount of weight loss with the improvement, and there wasn't a correlation in the acetazolamide group.
Say again.
So in the acetazolamide group, there must have been a range of weight loss from 5 pounds to 25 pounds. Did they do any kind of correlation in that group with that weight loss variable versus improvement?
In other words, did the
how
patients
how
that
much
got
of this is due to weight loss?
So they felt like, so the independent effect of the Diamox was the 0.71, so that the weight loss was controlled out of that. Yes.
You guys quantify the effect on headache?
Yes, I think I have that data in here. But HIT6 was not felt to be significant, but I'm pretty sure in some of the other quality of life measures there was headache in there. What do you guys really care about?
We like vision.
Did this, before you come to what's next, did this really test the relative efficacy of the different acetazolamide dosages? You didn't really address that. So there were some patients that were getting 3/4 of a gram, some patients that were getting 4 grams.
So they were,
In other words, is there a dosage effect?
So patients were titrated depending on their symptoms, their disc appearance, and their visual fields. So they would come back monthly, and depending on their change in their visual field or their optic nerve appearance, they would be put on an increased dose of Diamox.
But if I remember when I read this, there was no real independent test of dosage. They tested placebo versus acetazolamide.
Right.
They did not independently test 0.75 grams versus 4 grams. They just simply had a sliding scale.
Correct.
So it leaves unaddressed the question of how much you really need to get the effect.
I don't think this is a large enough study to really answer that question.
Yeah, it may be, but
And I
Plus,
don't.
if you weren't improving, they increased your dose. That makes it harder to.
No, so they started. They were just titrated up to when they were improved. They didn't have to keep going up.
Right. But if they didn't improve, they got a higher dose.
Right. So yeah, I don't think there's necessarily one dose that's right for everyone. I think you're asking if 2 grams or 4 grams is necessarily better than 2 grams, and
or even 3/4 of a gram, the lowest dosage.
well, they got started on 1 gram, so not even 1 gram was the starting dose for this. And actually, they used the 250 milligram tablets rather than the sequels, which I tend to use because I feel like it has a better side effect profile. But they use the tablets, I think, because they're easier to titrate, and in terms of compared to the placebo pills, we needed to use the tablets. So next will be the surgical arm of the IIH-TT. So these will be with patients with more severe vision loss, looking at optic nerve sheath fenestrations and shunts. This is still waiting to get approval and grant funding, but we're hoping to be a site here for that. Yes?
Question, I have a couple patients who I follow who seem to be very resistant. Maybe they can just go to one doctor, so they don't want to go to the ophthalmologist, and I try to get them to go to the ophthalmologist. And a question for you, can people have resolved papilledema and still visual field loss? Like, do you see?
Yeah, so they can have permanent changes on the visual field that don't go away. I mean, certainly if patients have progression and have severe vision loss, severe peripheral constriction, or decreased acuity, that's permanent. So even in the more milder forms, we do see permanent changes sometimes.
I guess what I'm asking is, can that develop? Because your visual field, I mean, your whole exam is better than mine, but I don't really do the visual field testing. And can you get better, and never get papilledema again, or have normal looking discs, and still have visual field problems? Develop, I guess, is the question.
That would be unusual. It's a little bit controversial whether or not you can truly have IIH without papilledema. Certainly if patients have had significant papilledema in the past and they have secondary optic atrophy, and if they have recurrence of the disease, we don't necessarily see swelling because there's not enough nerve tissue to swell. And so that can be a little bit more challenging to assess. But if they're having visual field changes, we'd always want to make sure there's nothing else going on that could explain it. Or sometimes people just have a bad day. I think there were a lot of patients in this study that looked like they were progressing, and they came back another time, and the visual field looked like it did 2 times ago, and they actually coined it the bad hair day for the visual field. I mean, it's a subjective test, and it can be very boring. And you sit in a bowl and press a button when you see a flashing light. And this patient population can be quite challenging as well, and so it's something that sometimes you have to repeat multiple times to see if there truly is progression.
So when you think about making escalations in the Diagnostic dosing, how long are you waiting between? How long are you waiting to look for change before deciding if you need to increase the dose? Like, are you increasing due to lack of improvement or only due to worsening?
So every patient's different. I think there's a lot. There's a lot of anecdotal, descriptions on how people treat. Even in the neuro-ophthalmology community, it's not like, I make a diagnosis and I say, okay, you need to come back in 1 month. It really depends on the patient. So if someone has severe disease, I may see them daily, especially if they get admitted to the hospital, for kind of this malignant IIH. If someone has, fairly mild swelling of the optic nerves, really minimal visual field changes, and some, annoying headache but not incapacitating, I may see them back in 3 months. So it really depends on each patient. In terms of when I'm adjusting the dose, again, if I'm seeing some progression of the visual field, that correlates to some worsening of the papilledema on the exam, I'm going to be a little bit more aggressive in terms of increasing their diamox. But if we start them on a dose and they come back, their visual field and swelling looks about the same, but they're saying, my headache's just not controlled, I'll kick them up on their acetazolamide then too. So, yep.
Back in my day, it was thought that some of the etiology was related to the women would store estrogen or estrogen-like compounds in their fat, so the total level may not be more, but they release more in the circulation, including salt-retaining, fluid-retaining.
Yeah, I don't know if there's really been any good evidence in terms of the estrogen. I think there's always a question: why is it overweight women? It's very unusual for men to get it. We do see it sometimes, but we're always trying to look for other causes for men. So there's some thought that it must be hormone related, but I don't think that's really been proven yet. Yeah.
When do you use topiramate?
So the question was, when do I use topiramate? Sometimes in the setting of mild disc edema, minimal vision loss, but uncontrolled headache. that may be my first line treatment if I think they have maybe another headache syndrome at the same time. Patients that, for whatever reason can't take acetazolamide, or if I'm ramping up the Diamox and they're having some side effects, don't want to go higher, but I feel like they need something else, then I'll start topiramate as well.
I was interested in the figure of 5% were familial.
Yeah.
Which is higher than you usually see in the literature about this.
Yeah.
It's often said to be like 1 or 2%. And since I like genetics, it's perfectly conceivable that the reason these obese people are different from the run-of-the-mill is there's something genetically different about them. And not much is, I saw there was a GWAS study,
Yeah, I don't think,
not much has been done with the genetics of this disease.
I think this was too small a sample size for that.
Yeah.
So I had a question about that kinky-looking optic nerve. How does that come about?
It's got to be something in terms of the intraorbital CSF pressure, but I'm not quite sure specifically why it. You're saying that vertical kink?
Yeah, in other words, it changes its shape. What dynamic would cause that?
There must be some, so the optic nerve is longer than it needs to be for the length that it travels. I don't know if there's some posterior pressure causing it to kink. I don't know.
I mean, it's okay not to know. It just proves that we don't know. So you've looked at this, and it's been a pet interest of mine for a very long time. What do you think? Just give me your heartfelt, intuitive position on this. What is the pathophysiology of this condition? I mean, you can't help but have some.
Yeah.
You got to think about what causes this. I'm curious what you think. It's okay not to know.
I don't know. I don't know. I think we were all hoping for something from the CSF analysis, or the genome part of it. There are a lot more obese patients than get IIH, but I don't have a good theory at this time.
Do you have a
Well, a couple of things. One thing, people have speculated that obesity may put pressure on venous drainage from the head. And if venous pressure increases subtly, it may be a condition which is short of being recognizable as a venous encephalopathy, but enough to kick off some kind of a regenerative hypertensive response in the brain. So that's one possibility. Losing weight, one of the places you lose a lot of weight in a hurry and early on in weight loss is in the neck. People drop big neck sizes. If you've ever talked to an obese man who's lost a lot of weight, the first thing that person has to replace is the neck size in their shirts. So that's one possibility. There's been a lot of conversation about this lymphatic drainage system. I don't know if our presenter today has paid any attention to that, but that's a very interesting new concept about where CSF goes. And if there was a problem in that drainage, perhaps because of an infection that caused a little bit of, perivascular alteration, maybe a loss of aquaporin 4 and astrocytic emphy, it would completely disrupt that flow because it's exquisitely sensitive to that. And that's occurred to me as a possibility. So those are just two random thoughts. Ransom.
So I don't think it's physical at all. I mean, why shouldn't it doesn't happen in a 400-pound man?
That's true. That's a good point.
So
so it may interact with hormones.
I think it's hormonal. I think it's hormonal, but it can't just be hormonal because not all 25-year-old obese pregnant women get it. So there's, it's hormonal with some other
Hormonal
factors
plus,
playing a
hormonal
role.
plus, but it certainly interacts with weight.
It does, but that could change what's
Yeah.
going on with hormones.
It
There's gonna kind of feed
Thing
that
is, we
system.
don't have to see significant weight loss for improvement. You know, these patients can still be obese, and 6 to 10% for some of these patients is they're not, dropping to 200 pounds.
But you have to admit that in the acetazolamide, arm of this trial, there was a huge weight loss, a double at least. what
Yeah, but
was-
other studies have shown the 6 to 10% weight loss. That's why that was the goal for this study. So just
6%, right? That's right.
Yeah, so just modest weight loss can show significant improvement.
Do you believe that, you said CSF is normal, it's theoretically normal, but it seems slightly different. The protein content of CSF from these patients is almost inevitably, and I think in this trial as well, the CSF protein content was low. I mean, not pathologically low, we don't even talk about pathologically low, but just it's a standard deviation off the mean of normal CSF. What's that all about?
You want another what's that all about? Do you know anything about vitamin A and tetracycline and what those have anything to do with CSF? I don't.
I mean, because some patients with tetracyclines get horrible IIH that is rapidly progressive.
Is there anything about what that has anything to do with CSF?
So years ago, we saw a pediatric woman with this, who was a Turner syndrome. She was a chromosomal XO. We always thought, boy, that's some kind of important clue. But I don't know what the clue was.
We got a couple questions on the screen from Harvard.
Do you recommend performing OCT in patients with IH? I often do. So OCT is optical coherence tomography. It measures the thickness of the nerve fiber layer that makes up the optic nerve. We use OCT in a number of different modalities in ophthalmology. It can be helpful in mild disc edema to track improvement. If you have significant disc edema, often higher than a grade 2, we just don't get very accurate measurements on the scan. But when you're looking for kind of subtle changes over time, it can be helpful. Great talk. Is there a dose equivalence between topiramate and Diamox? No. Would the benefit of Diamox be eliminated if you use, I don't know what that is, Uracid K? Do you think the benefits of high-dose Diamox could be more weight loss than direct CSF effects? Well, I think, oftentimes we're seeing a benefit with high-dose Diamox prior to seeing significant weight loss, at least what I've seen in clinic. And lastly, you mentioned the problems of a VP shunt. What about LP shunts? Those have problems too. So, but I certainly have patients that I've sent for shunts, and so I think with the image guidance that they have now, with programmable shunts, potentially we have improvement in terms of long-term effects. But you're always going to run into problems with shunt malfunctions. Are there more questions?
You could pull that little bar down. See the.
I don't see it on. Oh.
My question is, do you think this is self-limited, and when do you start titrating off Diamox?
I think it is usually self-limited. And sometimes I'll see patients that have been on Diamox for 6 years. And so if I see resolution of disc edema, resolution of symptoms, I'll start talking about titrating off. But I like to also see some weight loss too before I'll do that. Sometimes we're just unable to get that, but and then I'll follow them closer for a little bit to make sure they don't have recurrence as I'm tapering them off.
I think we tortured you long enough. Thank you so much.
Well, thanks for having me.